Good morning, everybody, and thank you for joining our last IHC Opioid Guardianship Quality Improvement Project. Today I'm joined by Sarah Durr. We also have Brian Isis and Kathleen Pedlow on the phone. I'm going to ask that everybody puts their phone on silence at this point except for my speakers, or on mute. And then also I have a favor to ask before we get started. If you are sitting in a room with more than just yourself, if you could please put in the chat section how many people are in the room with you. If you have more than yourself, that would be wonderful. And I know that some people have law enforcement or different groups of people. If you could also put who is in the room with you, that would be wonderful. Once again, Sarah Durr, who is our new pharmacist. She is here at Iowa Healthcare Collaborative full-time. She's doing a lot of great work. She's working not only with the hospitals, but also with the clinics. And we are very pleased to have her available to all pharmacists and quality staff to help move forward in medication safety efforts. Just to review, the reason that we are doing this project is to ensure patients on opioid medications have treatment plan goals of therapy with care plans if adjunctive opioids are needed and decrease opioid use. So when we look at this comment, I think to go back and say, where did we start? And then really to celebrate, we have a couple of speakers today that I'll introduce and many more of you that I have not met with and talked to. We do want to know all your successes and where you headed, because just thinking about starting here and where we've been and where we're going, and then hearing from Brian at the beginning, the rapid cycle improvement process, we're doing this. And I'm so proud of all of you to be doing this national groundbreaking work. So applause to all of you. I did want to share some data through the Compass HIN and how we looked at why should we do this, you know? So the adverse drug event rate you're seeing here on the screen, the baseline is January through December 2014. We have increased the number of hospitals reporting to HIN, so that could be some of the reason of the increase. But as ADE rates were slightly declining over time, naloxone usage was trending upward. So this is showing our Compass HIN data on stat naloxone administered outside the emergency department. So we're looking at the inpatient population that was receiving this. The baseline is from January to December 2014, and you can see how the data is trending upward, but still remains low at below 1%. But let's not get comfortable with this, because we do know that opioid crisis has not hit us, and it is projected to hit us in 5 years. So the work that we're doing right now, I think we can bypass that. Looking at the measures that we are have implemented, especially in this cohort, the opioid therapy treatment plan. Number of patients discharged from a hospital on opioids with patient-specific goals of therapy at discharge over the number of patients discharged on opioids. This is a self-reported measure. And I know a lot of people who came into this project, they said, we really don't have an issue. But some hospitals are seeing 75 to 80% of their patient population that is being discharged on opioids. And this is, you know, we're looking at developing this therapy at goals of therapy at discharge in this care plan, this individualized care plan. But more importantly, what we're seeing is wow, we really did not know we had that many patients that we were even discharging on opioids, and we really do need to pay attention to this population. The second one that we added just for this group, and if you are on the line and you're not currently participating, your improvement advisor is happy to add this for you. But we're looking at the number of episodes where a reversal agent is administered to patients in the emergency department over the number of patients in the emergency department. So again, expanding that, not only looking at how many people are getting naloxone on the inpatient population, but also how many are getting it in the emergency room before they come to the inpatient population. And I think as we move forward, we're going to see that this is very valuable data to be reporting. And once again, this is self-reported data. So what I'd like to do is thank you all. And without further ado, I would like to introduce our first speaker. Susan received a Bachelor of Science in Nursing from Grandview College, a Master of Science in Nursing from the University of Iowa, and is ANCC certified in nursing administration. She is proud to have served as Broadlawn's nurse since 1987. She has served in the positions of staff nurse in the Family Birthing Center and OB clinic, Director of Women's Health Services, Director of Imaging Services, Operations Director for Acute Care, and for the past 10 years as Chief Nursing Officer at Broadlawn. In this position, Susan is responsible for the coordination of nursing services, quality, and accreditation compliance across the medical center. So Susan, thank you so much for joining, and I really want to say this. When we look through the tools that we did promote and also work alongside with you to put out to all of the participants of this cohort, I want to thank you and your facility for helping us with these and actually giving us the template to work with.
You're welcome. It was a good effort with our group, so we're happy to be a part of this. So thank you so much for asking me to share with you our work so far in this project. Broadlawns became involved in the project ultimately because it made sense to be involved. We know that this is a significant issue in our community. We see patients coming in frequently to our ED with overdose issues. Then they get admitted to the ICU. They may receive behavioral health care for their substance abuse, and then they're readmitted for similar concerns. And then we see the impact that this has on those patients' lives as well as their families. So we pulled together an initial team of about 7 people, clinic and ER nursing directors, a pharmacist, and a family practice physician. We reviewed the materials that were initially sent out by the collaborative, discussed what we were seeing in our own hospital, and started to try to narrow down the pilot patient population group for the project. Next, please. Next, please. Okay. We began with looking at our data. First of all, the adverse drug event rate, and you can see that it's kind of jumped around over the course of the last 3 years and has trended downward about 10% or so. But we've seen nothing really identifiable as particularly alarming or something that we did that made a whole lot of difference either. Next, please. We added a question to our ED intake forms to capture naloxone being given in the pre-hospital setting, whether it was by EMS, police, or by family. And we just started gathering this data in March. Actually, we've been surprised by how few instances we're seeing with this being given in just these first few months of monitoring. We thought that it might be much higher than that. One option that we're just currently exploring a bit is the feasibility of or need for our public safety staff to possibly carry naloxone as they respond to issues in the parking lots and surrounding area. We haven't determined yet if we'll be implementing that particular intervention or not. Next, please. As far as ED naloxone administration, when we review the actual cases where this has happened, we do very occasionally see a post-op or a chronic pain patient coming in with opioid overdose of medications that were actually prescribed for that individual. But the vast majority of overdose patients appear to have ingested heroin or other non-prescribed opioids. We're currently exploring the potential for Broadlands to be a narcotic disposal site ourselves rather than needing to send people somewhere else. There are concerns, of course, as far as the security of the materials, where we can place the receptacle, where it will be constantly monitored. We're trying to work through some of those concerns now. We're also working on implementation of the narcotic disposal handouts throughout the medical center. Something else that we did explore, we're using the examples for signage in the ED and our urgent care as far as not renewing opioid prescriptions in those patients. We had excellent buy-in from our providers in those areas. However, we're now running into some EMTALA concerns as far as the potential for it appearing as though we are discouraging patients with pain from being seen. So we have not been able to post those signs or even to use the handouts for patients stating that position at this point. Next, please. Next, we looked at the instances of giving naloxone outside of the ER. And the instances where we actually gave naloxone on one of the inpatient units were most often, although not always, related to post-op patients. So usually those receiving patient-controlled analgesia or other IV push pain medication. And we had already done some work with our orthopedic surgeons earlier in 2016 as far as their post-op orders, trying to eliminate some of the issues that we had with some therapeutic duplication and some ambiguity that we knew had contributed to some of these instances. And you can see we did have some success with those changes. The group decided then that this same post-op ortho population made the most sense for our pilot project as well. And we did then further narrow that down to just total joint replacement patients. Next, please. So our team expanded once we had identified the pilot group. We added a nurse, a physician from the ortho clinic, a case manager, and a physical therapist. And in discussing the overall goals of the project, we decided that we also wanted to have representation on the chronic pain side of things. So we added a nurse practitioner from our pain clinic and a psychiatrist with a strong interest in addiction treatment. The group developed a draft of a comfort plan based on the various materials and examples that the collaborative had provided, as well as some research into some comfort scale options. The back page of the plan includes the comfort menu of non-pharmacological pain relieving measures, things such as warm blankets, repositioning, music. We began utilizing this plan in August with our very small, actually, numbers of patients who have total joint replacement. We've had 9 patients since we began this project. In the week prior to their operation, the ortho clinic nurse has a discussion with the patient and tries to engage them in helping to plan what they'll be doing in the hospital for pain relief, as well as once they go home. She helps them set realistic expectations and some goals for their comfort, both at rest and when they're about, and works with them on how they could meet those goals. So what combination of opioids, non-opioids, and items from the comfort menu they could utilize at each of those stages to reach their goals. And this includes the concept of the comfort scale, introducing that to patients as opposed to the pain scale. As this was rolled out, it became clear that we needed to provide some additional information specific to opioids. The reality is that they're going to be taking some after this type of surgery. So we want to be sure that they have the needed information about how to do that safely and then how to begin to taper off of them. So we added to the back of the comfort plan some general information about taking opioids safely, tapering, and then also modified the comfort menu on the back. They could be just those interventions that they could reasonably implement once they got home. Again, to try to engage them in planning for their discharge and what they will need to share with their family about their recovery. Additionally, we decided to modify the table at the top to include the time in the hospital so that it could be included in the pre-op discussion and in the goal planning. The clinic nurse visits the patient in the hospital post-op, reviews the plan again with them prior to discharge, and then a few days after discharge, she follows up with the phone once they get home, checking on how they're doing in general, and then also specifically related to their comfort. Are they following their plan? Are they, the use that they have of the medication, some of the other measures that they discuss. And she checks in again periodically with them over the next week. Or if they call in for a refill of opioids, she's discussing with them just to be sure, are they starting to use the anti-inflammatories? Are they tapering off of the opioid? Reinforcing that pre-op education about the importance of doing so. And earlier this week, she did relate to me that she's very pleased with the patient response to the effort. She said they want to be off of those opioids post-op. Next. An additional tool that's used when the patient is in the hospital is the comfort scale. And currently we're using this post-op on the medical surgical floor along with the pain scale for that total joint patient group. And we haven't managed to get completely away for the pain scale, even with the pilot group. We've had some mixed reaction from nursing staff. We've done re-education a number of times trying to get some buy-in. And at this point, we're just documenting in narrative notes about the comfort scale. This will be a lot easier when we can make the switch, we think, for all of our patients house-wide to using the comfort scale instead of the pain scale. And we're kind of waiting right now for our upgrade of our electronic health record that we're in the middle of. When that's all completed, then we're hoping to move to this scale house-wide. One thing that we did decide for future that we want to change on here is to eliminate the little stars under the faces that make it look like a numeric scale again. This has just been too confusing for everyone with the pain scale being numeric as well. And so we want to eliminate those, the little stars in the future. Next, please. And this is the comfort menu. This is used on the inpatient unit. And this is actually a tool that was already developed as a patient satisfaction initiative and had already been partially rolled out prior to this project. We're utilizing it now for this purpose, and we use it to highlight the alternative options that are available to patients. Again, hopefully to reduce the amount of opioids and to hopefully decrease adverse drug events. It provides the patient and their family with another way to have some engagement and ownership in their care by offering them some more choices and options. We have this laminated and available at the bedside for all of our med-surg patients, not just our pilot group. The admitting nurse reviews this with the patient, and then it's offered periodically thereafter. One change that we made recently is to begin having the environmental services staff put this on the overbed table as part of their room setup after terminal cleaning of the rooms, because this is something that sort of tends to make its way into the bedside tables otherwise. And we've had good response from patients to the use of the comfort menu. One of the ICU nurses heard about it earlier this week and asked me for some, so we're getting those in the intensive care unit now as well. Next, please. So right now, we are trending the number of patients who are discharged home on opioids across the medical center. And what we have found is that an average of about 34% of all of our inpatients, that includes both medical and behavioral, and about 41% of all medical inpatients are currently discharged on an opioid. Since our intervention just began in August with the patients in the total joint replacement group, you can see that our data on here looks as though we're at 0%. We don't have anyone going home on an outpatient therapy plan. Once we can start plotting August and September and data from then on, you'll see that trend line going up, however. We are using it with 100% of the total joint patients. And then our intent is to roll this out to other types of post-op patients next. So what we're currently working on is reinforcing some of this with the inpatient unit staff, using that comfort menu, using the comfort scale, developing some ways to document those comfort interventions for all of our patients, and modifying the whiteboards to reflect the comfort scale and the goals for comfort. and then figuring out the modifications to policy and medication order sets that are needed to make the move from a numbers pain scale, which is right now tied to our definitions of mild, moderate, and severe pain, to how we can now make that reflect the comfort scale. And we're finding those are some significant issues that we still need to work through. Next. So thank you for letting me share with you our efforts so far.
Susan, thank you so much for sharing. I think that everything that I heard you say is so important. I love all the ideas that you gave. I really love that you said, you know, when we look at you guys doing the treatment plan, we haven't seen the data. We just started in June. So when we start seeing the plots come forward in August and September, we're going to see, you know, really good movement. So does anybody have any questions? You can unmute your phone or comments for Susan.
What EMR does your hospital use?
We use Meditech right now, and we just made an upgrade to, I think, 6 point something. It's a major upgrade hospital-wide.
And have you found that the EMR parent company is kind of willing to help with some of these changes?
The parent company really doesn't do many of the changes. That's all really done in the hospital by our own IT department.
Thank you.
I have a question about orders and order sets. If you use any kind of orders that are tied to the indication for, like our orders right now are tied to an indication of pain, moderate, mild, or severe, did you have to go through this change, or how did you handle your orders for pain based on, or pain meds based on their rating of pain?
That's what we're in the middle of right now, is trying to transition that. What we're kind of looking at is on the comfort scale. If you look at the last three items where they say that they're somewhat uncomfortable, and then uncomfortable and very uncomfortable, one of the things that we've been thinking about is having somewhat uncomfortable be equivalent to mild pain, uncomfortable, moderate pain, and very uncomfortable to severe pain. So far that's what we're looking at for trying to translate those orders, but we haven't done that yet.
I'm going to share a couple questions that have come up on the chat. One is from Covenant. Can your comfort plan be posted on HIN? I would like to see the tapering plan they have on the back. So Susan, if you'd like to get that to me, we can get that posted on Hinnovation.
Sure.
And then did you build your tapering plan electronically? If so, could you provide the screenshots of what that looks like? We also use Meditech that comes from Fort Madison. And the next question is, okay.
I'll just say that all the plan really is talking, it's very general statements about, at about this point in your post-operative recovery, we would expect that you would start decreasing the numbers of opioids that you're taking, and then at about this point, we would expect that you would be decreasing. So it's not really anything that you graph out or have in anything like that.
Okay, any concern about changing to the comfort scale from the pain scale, since patients will still be asked about pain on hospital surveys after the patient leaves?
Absolutely. I think that's probably one of the biggest questions that we have. I think we're going to have to prepare patients for that question when they get the survey, and just talk about it at discharge, that you know, we utilized comfort when you were here. The survey that you're going to receive when you get home is going to say pain, and here's why there's a difference.
And we do have another question about the comfort menu being put out in a different format other than a PDF file. We are working on that right now. some of the things that we have been producing the resources so rapidly, it's hard to keep up sometimes, but we are working on that right now. Okay, any other questions for Susan? Okay. All right. So Susan, once again, thank you for all your efforts and thank you for sharing. And please come to our Iowa Healthcare Collaborative annual meeting to hear Susan's results in November, as she also will be presenting there. Next, I would like to introduce our next speaker from Murtu Medical Center. Nancy Gao has been the Director of Pharmacy of Murtu Medical Center in Harlan for 5 years. She graduated from Creighton University's PharmD program in 2002 and also received a bachelor degree in biology as an undergraduate. She did her interning for Children's Hospital in Omaha, Nebraska during pharmacy school and worked for Children's Hospital upon graduation. She also has worked for Walgreens. She worked retail for 10 years and in 2009 went to work for Cardinal Health as a nuclear pharmacist. She received her certification for nuclear pharmacy from Ohio State University and still works part-time for Cardinal Health today. In 2012, she decided to make a career change and came back to her hometown of Harlan to become the Director of Pharmacy. Nancy, welcome. And if I could ask that everybody put, yep, I can hear you. I'm just going to ask that everybody put their phone on mute at this point if you're not speaking. And Nancy, you can go ahead. Thank you.
Okay, glad to be here. If you want to go ahead and put the first slide up. The first 3 slides we won't spend a lot of time on because I want to get to the last couple that have things that we've done the most here for this opioid stewardship. This is just some stats of our adverse events that was over the year of 2014, and we had a really good year that year and really brought our rate down by 90%. And that really happened with collaboration of pharmacy, QI, and nursing, working together closely, communicating, having daily huddles, the med-surg nurse and myself with weekly huddles and a monthly meeting with the med-air team. And so I do have our performance rate for this year, and it's even lower. It went down to 1.45. So we've done really well. And that, like I said, that was a collaboration of working together with across the board with QI and nursing and myself and my pharmacy staff. Next slide, please. This is our stat Narcan administration outside of the ED. We really have not given a lot of Narcan in-house. We've always kind of tracked that for the last couple years, actually, and do pretty well. We did have maybe a couple cases here I've seen over the past year, and really, actually, probably shouldn't have had Narcan with what was going on. So, and then we just did some education about that, of when to use it and when not to. So we actually do very well with that stat in-house. Next slide, please. This is our Narcan that it's administered in the emergency room. This is just developing. We just started collecting information. It's going to be one of our QI measures this year. It's pretty spurty, the Narcan use in the ER that I've seen, going back and looking at charts and looking up the use of the Narcan. And so we're just moving forward with that. Our physicians they will use the PMP on patients that come into the ED. And we actually do have charts up in the room stating, and I can share that as well, stating what our purpose is and how we will treat pain in our ER. and it's actually worded very well. So if anybody wants that, I can share that as well. Next slide, please. This is getting a little bit more in depth. Our Statins Alone administration in the community setting is going to be one of our QI measures for this year. And what we did was we had to establish what we're actually seeing in our community. And so we did have a meeting on July 31st of this year, and it was about 12 people from our community, which involved the police department, fire department, the superintendent of the school, behavior health, ED department, home health department, myself, and the paramedics. And it was a very interesting meeting that we had, and we had to establish, like, what are we actually seeing? And what we did find out is that we found out a lot of information from our police department and from the Shelby County Sheriff's Department. And we are seeing, overdoses in the community, not just from prescription drug, but also from the heroin, fentanyl that is on the street right now. And what they're saying is that as physicians are releasing their patients from prescribing so many opioids for them, they are turning to this heroin, fentanyl cut on the street. And so they are seeing that pop up a lot more often. And so what that raises is, we wanted to know, is the police carrying Narcan on them to protect themselves as well? And they're actually not. And we found out that was kind of an economical issue with their department, and as with the fire department as well. The paramedics in our community have also seen this as well, and they are taking precautions by wearing masks and gloves, because it can be inhaled, and you can go into respiratory arrest by just breathing that dust off of you. One of the police officers did say that they know of a officer, not in our community, but in a close by community, who brushed it off his clothes and went into respiratory arrest. So I think it's very vital that they do carry Narcan. And as a community, after this meeting, we did decide that we were going to work together to raise money, apply for some grants to supply Narcan for our police department, fire department, and make sure that our volunteer rescue squads in the small communities surrounding Harlan are also provided with that and educated on it. I think it's very vital that you do find out what's going on in your community. And so what we also decided was that we would, MRCU would extend our knowledge out to the community and help the school with teachers and counselors and the superintendent, and educate them on some of the stuff that we're seeing in our community, and educate them on the use of Narcan. Because what we found out from the superintendent, he doesn't even know what Narcan is, and he didn't really understand what was all going on. So it was just a really good meeting to get everything, focused on what's going on in our community. The other thing is, too, that for our stats, the local paramedics did say that they would share their the number of cases that they have in Mason, because they may not always come to Harlan. And so they will share that with us and surrounding small communities that are very close to us. So we'll be able to get those stats from them. We can move on to the next slide. And moving on with our opioid stewardship, what we've done here is in our clinic, you have to reach out to everybody, not just your hospital. And so we also got information from our clinics as to what we do there. And we've actually had a pain management education agreement in our clinic for 5 years. And we base all of our criteria off SOAP scores, and how those patients evaluate on those SOAP scores will determine what we do as far as their opioid agreement that they sign. We have added some pamphlets and different literature to the packet that we've gotten from HIN, and that is providing waste sites and rehab sites that they could reach out to if they do want to discard of some of those opioids. We do have a pharmacy in town that did qualify for a waste site, so that was nice. All of our physicians are signed up with the PMP, and there are requirements if you are on that pain management education agreement that you do have to look up on the PMP for those patients according to that agreement. And they can look it up on any patients. And one thing that we are encouraging right now is for them to, any new patient that they come in, look that up and have a baseline with that patient and know right away if there is going to be an issue. One thing that we do require in our clinic that maybe other clinics don't require is that if you are getting any kind of narcotic, and that is a 2 through 5, you do have to pick up that prescription at the clinic. And we just decided that as an establishment. Obviously, it's not a law, and that is just that they are committed, and that we can see behaviors as well. And moving into our hospital setting, what we did with our hospital setting to roll this out is we had to pick a small group of people because it's just too big of an issue to implement all at once. And so we did pick our ortho patients and acute surgical patients that come up to the floor and are using them as our trial group. And what we did as well as we switched all of our pain scales over to comfort scales and educated the nurses on that. But one thing, as coming from a pharmacy perspective, I want to just say that our pharmacy is very involved. Our pharmacists are very involved, and when I first came here, it wasn't so much that way. And when we did start becoming very involved in helping the nurses on issues like this, it really took a lot of pressure off of them and a lot of pressure off the physicians. And so I just think it's important that you do utilize your pharmacy and your pharmacists. They have a lot of knowledge, and people want to hear from their pharmacy, and they want to hear from their pharmacist. I hear that all the time when I talk to patients. We love to hear from our pharmacists. So that's something that's important that you implement into your hospital, I think. And moving on, what we did when those patients come up to the floor, those surgical patients, we immediately established their goals and where they fall on that comfort scale. And we explained the comfort scale to the patient very well, and how we want them to have a goal every day and push forward every day and improve that goal. I think you really have to start from the beginning in educating that patient about their narcotics and about pushing through the pain sometimes. And our ortho doctors are very much about that, and they as well come in and talk to our patients about that as well. So that is very nice. And as the pharmacist every day, we track the use of those narcotics and everything that they have on their chart that can be used for pain. And that's not just narcotics, that's things that are not narcotics as well, and see how we're using them, and we document that for the physician. So when they go to discharge that patient, they have good documentation of what they've been using. And if they haven't been using, like a hydromorphone or a morphine much here, maybe we don't really need to send that home with that patient because they've been doing very well without it here and getting up and doing therapy without it. So that's something that is helpful as well. The other thing that we did was bring back the comfort carts. We will put stress balls on there, chapsticks, gadgets that they can play with their fingers to take their mind off their pain. And we also counsel them on doing stuff like that as well when they go home. The one thing that we did make mandatory here is that the patient cannot go home discharge on an opioid without the pharmacist coming down and doing a thorough discharge on pain medications and their pain packet. And what we do is we go through and we explain very well between mild, moderate, severe, nerve pain, all the difference between that. We go through, obviously not every patient's going to be discharged on the same medication. So it's really patient specific. So I think that's one thing that we have to realize, that when you're talking about tapering a patient down off of a medication in a pharmacy perspective, it's going to be very patient specific. So you can't really tie that all into one patient. You've got to look at your patient individually, see where they stand with their goals, and also what you need to do to taper them down off of that. So we may look at that a little bit different than nursing and even physicians, and that's why it's good to bring the pharmacy perspective into that. What we do is we go through that whole packet. They have things in their packet that they can chart their pain, chart when they're having more severe pain, and they can take that to their physician on that follow-up. But we do go through a good tapering scenario with that patient and what we want their goals to be and what we kind of expect of them before that follow-up visit with those opioid patients. Some of the cons that we've ran into is obviously the training of all this is a con because we have such a large group. We're not a 24-hour pharmacy here, and like narrowing that in. So what we did was we took the charge nurse and the core nurse and we trained them first, and they became our pain specialists on the floor, and they're the ones who get assigned those patients as they come up. And as we get better and we get them trained well, they will reach out and start training the other nurses as well, as we will do in unit meetings, orientation, and the annual yearly training with nursing staff to get them all trained. And the same lingo. Pharmacists are responsible for educating the medical staff at med staff meetings, executive meetings, and also getting them on the same page and the same lingo as well. The pros, I will tell you, that we've seen so far are better patient outcome. And what I mean by that is the patient feels more informed and they feel more control of their pain and what they can do for their pain, the more that we do a better job about counseling and keeping them involved in their care. And what we have found with our follow-up phone calls is just that they, yeah, they do have pain, but at times, but they are able to have resources to go to because they have been informed before they leave. And of course, we always leave, I always do when I counsel a patient down the floor, I leave my number up here, and they are able to call me anytime after they leave the hospital for information that they may need or just reassurance. So that's just some of the things that we've done here. So that's it. And if you have any questions, I'd be happy to answer them.
Nancy, thank you so much for presenting today. I know that Sarah and I both are smiling, writing notes. We have had a few questions, but I'm going to go ahead if you guys want to unmute and take some time to ask some questions on the phone to Nancy. And again, you may be on mute, so you may have to unmute. One question we did have is, what do you do for inpatients who are not clinic patients when it comes to opioid therapy treatment plans?
I have to say that we don't honestly see a ton of those types of patients here. But we may reach out to their local provider as well as do more follow-up phone calls to those patients to make sure that they're on the right track. Definitely give them a very good teaching before they leave. And our nurses do a very good job of getting that information. Like if we had a patient that came and was not from this area and maybe, you know, goes to another clinic somewhere else, of contacting and getting that information. And part of that has to do with our QI director here. She's very good about making sure that we're following through with those types of things with our patients.
Okay, wonderful. Another question, have you ever compared the patient satisfaction scores before and after this change? Did you compare those before and after?
Yes, actually, we've had quite an improvement. And I found, honestly, people just want to be informed, you know, and it's a lot easier to take care of something, and it's not just pain, it's anything with medication in general. if they have options to go to when you send them away. And so I really do, we have improved. Our scores have improved quite a bit. And I would say probably 30 to 40% since we've started doing this. And also I think the improvement is that they feel like they have options to reach out back to us if they have questions when they're at home.
And I bet your follow-up phone calls look a lot different now too. Have you standardized the counseling that the pharmacists provide? And what is your inpatient census like?
We're actually pretty busy for a rural hospital. Our average is anywhere from 12 to 13 patients at a time, but there's many a times we could have 20 to 25 patients here, and that's nothing. I mean, I've seen in a day where we go from 5 patients up to 17 in no time. So we get all kinds of patients, so you can get anything here. But we are pretty busy for a critical access hospital. We only have 2 pharmacists here, so it's pretty easy for us to collaborate on what we're saying to patients. We do have, like I said, a packet that we follow, and we've gotten together and have gotten our lingo, to be very similar. So it's a lot easier when you only have 2 to do that. And I can certainly share that with you guys if you'd like on HIN as well.
The next question is, do you ever dispense naloxone to patients?
We don't here. We needed to dispense naloxone. We do have a pharmacy in town that is certified, and we work closely with them. And they're also our pharmacy that is a waste site as well. And then if you dispense that naloxone, you have to have a 20-minute counseling session, because it's not just about administering that naloxone, it's actually knowing what to expect after you give it. And so they do have to go through some education in order to get that. And so those 2 pharmacists at that retail pharmacy are certified to do that.
Okay, and then our last question is, how do you track your inpatient therapy plans?
Sorry, what was that question? I'm sorry.
It's how do you track your inpatient therapy plans?
Like, what do you mean by that, I guess? Like, are you talking, like discharge, like what we do as far as, go ahead and just explain it. It'll be easier that way.
Okay, that question is coming from someone else, so I'm going to ask that you rephrase that on the chat box. For the HIN reporting, how do you track the numerator and denominator for the measure that we're talking about? So number of patients discharged on opioids that are receiving a treatment plan. Are you sampling that?
Okay. Our sample, what I do is we keep track of all the number of patients that come through that are surgical or acute. And I mean, I'm sure everybody's computer system is different, but we actually keep track of that through the pharmacy because we do the measures here at our hospital. So the other pharmacists and myself keep track of those patients that we've been tracking. So anybody that's an ortho patient or acute surgical, we keep track of them so we know how many. And then we keep track of, obviously, we're actually at 100% of making sure that they get a education, and because we're in charge of it. I mean, I know that's probably not very easy to do, but they're not allowed to leave here without that happening. So that's why it's easy for us to track that at this point.
Very good. Well, Nancy, thank you so much. I think that we could go on and on with for a long time, but I'd like to move on to the next slide. We did talk about, I did send an email, and first of all, are there any other successes out there that would like to be shared? I'd just like to open up the line for that. You can either put them in the chat section, and I know that we have 10 minutes left, still some things to cover, but if you have successes, please unmute and share them.
Good morning, this is Megan Mullenbeck from Hanson Family Hospital in Iowa Falls. And I would just like to talk about our success with our community presentation that we held in August. We had, I would say, an extensive planning committee around that. We were able to host 34 attendees. And since that time, we have been asked and continue to be asked to present at community groups on this subject. And we will be working with Jennifer, as she's our improvement advisor, to bring a presentation back in 2018. Our community and partners are very interested in this epidemic and what we can be doing about it in our community and how we are discharging patients with the proper information and how we can keep everyone safe in the community from this. So,
Thank you, Megan. And I know many of you have had community meetings, and actually, Nancy, we're coming to you. Sarah's going to come tonight to do a community meeting, so I think they've been a huge success. Just so you know, we do not have the ability to go to every facility after. We are going to do another cohort that's going to start in January. We will be sharing the community presentation in November and updating that so you can go ahead and present that. And of course, we would offer training on how to do those webinars. Any other successes that would like to be shared?
I'd like to make one quick comment. This is Dr. McElderry. I'm a family physician, and I've been dealing with helping develop opioid guidelines for our clinic patients for 4 years now. And we have a new opioid policy for Methodist Physicians Clinic in the Council Bluffs, Omaha area, and we're starting to educate providers. So I've had a couple presentations I've given, and it's becoming apparent that there's a need for having a more standardized transition from hospital to back to the primary care physician when there's pain medications involved. So my thought is that especially when you have hospitalists transitioning to the primary care physician, that perhaps we need to come up with a number of days that's prescribed. I think it's very variable by provider, but if we had more of a standardized, I think in my idea is 5 days is reasonable and a tapering dose and transitioning to that primary care physician. I think that if it's quite variable, sometimes they're released to the nursing home and then they get callbacks and that the medications have to be faxed, and that makes it really hard. So you don't want to do 1 or 2 days, especially on a weekend, but you don't want to do a week or a month, because then you're setting up for possible diversion, not using up the opioids and side effects and so forth. So I just wondered what people's thoughts are on this.
Okay, wonderful. I'm sure there's more successes. Please share these on Innovation. I do want to move on to our next screen, which is barriers or challenges. So would anybody like to share some challenges and barriers?
Hi, this is Joyce from Dubuque, and I would say that our biggest barrier is payment of getting these third-party payers, and especially the Medicaid insurance companies, to reimburse for medication-assisted treatment and for the substance abuse treatment. It's just really a barrier in getting people to the right level of care.
Thank you, Joyce. Any other challenges that would like to be shared? And I do encourage, if you do have some successes or challenges or barriers, please email those to myself or Sarah. You'll see our information at the end, as we are interested in what you are coming up against, and also the challenges that you're overcoming that do turn into successes. And I'll turn it over to Sarah.
Thanks, Jennifer. So I just wanted to talk a little bit about next steps and where we're moving with the Opioid Guardianship project. Since we have done the initial cohort with the 23 hospitals, we will be expanding on that in 2018. So I wanted to share that with you all today. So of course we always look. Go ahead, Jean.
I'm sorry. We were just going to share a challenge that we have. We have Joint Commission coming probably within the next 2 months for a revisit, and one of our challenges are our medications. Sometimes we, I'm not going to say it's always that they're duplicate therapy, but in some cases they may be, and I'm thinking it's also going from a pain scale to a comfort scale when all of our orders are based on a pain rating. And then the fact that we'll have something that, you know, how do you transition that? And then our medical record is not something that we have control over making those changes. And I feel like a lot of this is going to be a culture change, to change from what the patient says their pain rating is to helping a patient understanding that it's not a pain rating, but it's a discussion about comfort. And I think it's also nursing as well that we have to make that culture change with.
Absolutely, I couldn't agree with you more. All of this work is definitely going to need to engage not only the hospitals, but the clinics and the communities to make sure that we have the same scripting across that whole area and that we are making that culture shift. So I agree, it's definitely going to be a transition that we need to make as a healthcare community as a whole. And I will add that a lot of the challenges that you just expressed are similar things to what Jennifer and I are hearing whenever we are out at our community meetings. So we'll continue to work on helping address those challenges and barriers that you all are seeing. With that, kind of back to next steps, we do look at this from a 3 pillars standpoint on combating the opioid crisis and reducing our adverse drug events. So first and foremost is that upstream prevention and appropriate prescribing, which is what the community meetings have been all about, and really what this opioid project has initiated the work on. The next steps, we will start looking more at addiction treatment and relapse prevention, and then finally we'll move into diversion prevention and medication disposal. And some of these are really being addressed currently in the project, but we'll continue to expand on those in 2018. I wanted to just draw attention to the person and family engagement piece. I know we heard quite a bit of this from Nancy and Susan today, and so I really appreciate you sharing your stories on today's call. We want to make sure that each tool that we are creating will engage the patient to think about their comfort level and have that education piece around that. It'll also allow the patients to choose what will increase their comfort, and then providing an action plan when transitioning home. I know we did have a question come up about transitioning from the ER to the clinics and how that all works for days supply. And we are working on some tools to assist with that transition between hospital and clinics. And then lastly, we really want to empower our patients to ask questions, especially around that treatment plan is where we really can see patients asking additional questions to understand their care and understand their goals and the opioid use. So we will be sending out a follow-up survey to the 23 who participated in our initial cohort, and these are our questions that we currently have and use for our initial survey. So we will be sending that back out in the next few weeks here. So watch for that if you are a part of the cohort so that we can get your results and compare that from our initial baseline over that 3-month time period of that cohort. And then moving forward, we are working on creating an opioid strategy for the Iowa Healthcare Collaborative as a whole. And what this will look like is really breaking down those silos between hospital, clinics, and communities to make sure that we are cutting across all of the projects we're working on and making sure that we are providing the best care to our patients along the whole spectrum. Since medications do follow the patient from each healthcare setting, we will be looking at not only the hospital and clinics, but also long-term care, mental health, and other areas that also need to be looking at opioid use as well. As we kind of mentioned, we will be doing Train the Trainer webinars for those community meetings. We definitely can't get out to all of the HIN hospitals Jennifer and I, that would be a full-time job for us. So we will be working on doing some webinars probably in January, February, to train anyone that is willing to do these meetings. They are very easy to do. We have the slide deck set up. Of course, you can modify that to fit your clinic if need be. But or clinics or hospitals, whoever you're presenting to, we are happy to get that information out to you. And I've already had quite a bit of interest from nurses, providers, and pharmacists who want to get out and do these meetings in their communities. So we will absolutely have that available in 2018. We are also planning to roll the Opioid Guardianship Quality Improvement Project out to all Compass HIN hospitals starting January of 2018. So we will have monthly webinars on topics related to opioids, and we're in the process of creating that format at this time. And then lastly, we are working on a 4-part continuing education webinar series, which would have the CME, CPE, and CEUs available for medical staff, pharmacists, and nursing. And we're hoping to launch that late 2017 or early 2018. We're just trying to work out the logistics of what that process is going to be to get all of the CE in place, and then also making sure we have our topics all set up for that. I wanted to remind everybody of the 2017 Compass HIN Learning Communities next week on September 26th. You can register online at this link or by going to IHC Online and searching events. It's going to be a really great meeting. There's a lot of awesome speakers coming in, and I think it's a great thing for your hospitals to get out to if you're available. And then also a reminder of the Iowa Healthcare Collaborative Annual Conference on November 8th of this year. Registration will be opening soon, again, on ihconline.org. And with that, I'm going to turn it back to Jennifer for a brief closing, as I know we are at our time.
Thank you, Sarah. And I just want to take this time to thank all of you. I know that you guys put a lot of work and you took a chance to get out and do this work, and you really did it. And without you, we couldn't be having the outcomes that we did. This is a huge success. Please share your success on medication safety, on innovation. Please send us your success. We will be highlighting many of your successes, and then Sarah and I would like to schedule a phone call with you later in October or November to go over your data, to show you the improvements, and also to find out what you're doing so we can help lead Compass HIN and the nation as they are paying attention to what we're doing. So thank you again. Please contact us, and everybody have a wonderful day.
Thanks, Jennifer.